So it's my pleasure to talk tonight. It's a moment of mixed emotions for me. Menzies has been a fabulous place to work for the last few years, and in particular the engagement that the community has with the Institute is something I've never experienced elsewhere. But what I'd like to do in the next few minutes is to review really why we're here, what we've done in the past, and the things that have happened in the period that I've been here. One of the questions I was first asked when I started in this position was, why is there such an institute in Tasmania? As in, why don't you wrap it all up and take it off to Melbourne? And the answer is, there absolutely has to be an institute such as this in Tasmania. There are several things about Tasmania that are distinct from the rest of Australia, and if you like, are a view of things to come in the rest of Australia. It's a population that is aging more rapidly than the rest of the nation. Unfortunately, poverty and the challenges that go with that are more prevalent here. And although it's not such a huge place, remoteness is a practical issue here. And all of these things are reasons for having a health research institute in Tasmania. So as all of you, as long-term supporters of the Institute would know, this began over 25 years ago, led by Terry Dwyer. And the first major topic that this Institute became famous for was sudden infant death syndrome. And Terry's observations in a large number of kids in Tasmania identified that one of the drivers of this process, sudden infant death, was laying children down to sleep on their bellies. And in fact, the change in practice that arose from that research has saved thousands of lives over the years. In fact, if Menzies had been able to write the script for its history, it couldn't have chosen a better story than this to begin with. And I think a fabulous example of how important biomedical research is to the community. Of course, that area of activity that was started in that particular topic concerns a major ongoing theme for us, and that is population health and public health research. And there's a couple of examples I want to show you that really I think have blossomed in my time here. I can't take any credit for it at all, but apart from to observe that I think that they're very important to the Tasmanian community. The first is the issue of environmental epidemiology that has been driven by Faye Johnson. Faye's work a few years ago documented the health benefits of changing environmental policies, particularly around Launceston. And her work subsequently has translated into an app which has just become available in the last couple of months, this Aerator app, which you can download from the App Store, which gathers data that relates to pollens, air quality, and temperature, and is of use to individuals to identify what are the circumstances that make their respiratory symptoms worse. So a great translational story that comes from this institute as well as collaborators. And the second aspect that I'd like to highlight in the population health area is the role of health economics, and we are blessed to have a health economics group here which has grown over the last few years and I think is a very important part of this institute's future and its contribution to the state. We all know that the cost of healthcare is increasing at a rate that is not sustainable, and one of the tasks that I think medical researchers have in general, and I think this institute has in particular, is to identify how best that can be controlled at the same time as delivering high-quality care. So the first part of this story began with epidemiology and population health, and the second part of this story began in the laboratory. And Simon Foote was the second director here. Simon's interest was in genetics, and that meshed very well with a long-standing interest in Tasmania about the genetic determinants of health problems. Something that is easier to do probably in this environment than many places in the world because of the contained population and the ability to follow people for long periods of time. And the group that has been involved in this, now led by Joe Dickinson, has identified, for example, genetic causes of blood cancers, as well as some prostate cancers. This is a very important area for the Menzies. And in addition to this, the laboratory area is important to us in other spheres. We have here a very strong neuroscience group, and I'm just showing a couple of examples of their work about cells in the brain and central nervous system that are able to replenish brain cells. And in this era of brain damage from dementia and Parkinson's disease and neurotrauma, all of this work is extremely important and is going on here in our basic labs. And then the other area that is really important has been our work in immunology. I'm sure there's nobody in this audience who isn't aware of this problem of the devil facial tumor disease. And led by Greg Woods, we have a group here which has developed a vaccine. You can see here the response to the vaccine. And as you've heard from the news, these vaccinated devils have been released into the community and could be a potential solution to some of the problems with facial tumor disease. So the third part of what we do is clinical research. And this particular building has been incredibly well designed to do clinical research. I often tell people that clinical research usually occurs in public hospitals under rather confined and difficult circumstances because they're busy places. And here we have a tailor-made environment for clinical research, and it's something that we are very appreciative to the community for supporting. In fact, this institute has a long history with clinical research. Graham Jones, the leader of our musculoskeletal theme, it was the Tasmanian Scientist of the Year a couple of years ago. He leads a group who are particularly interested in osteoarthritis and have had a huge impact both nationally and internationally, and nominated as one of the 10 best in Australia by the NHMRC. My area, and that of my colleagues, Jim Sharman included, is cardiovascular disease. And on the right side of this slide, you can see the causes of death in perspective. If only we saw in our newspapers the attention to cardiovascular disease that we see as attention to war or trauma. This is still a huge burden of disease in our community. And interestingly, we're talking about history to begin with. There's a mummy having a CAT scan there. So that mummy has calcification in the coronary arteries, which is a feature that goes along with atherosclerosis. Human beings have been dying from vascular disease for millennia. This isn't a transient problem, it's one that we still need to solve, and it's particularly a problem in Tasmania. Now, our group has had made significant contributions in this area. You've probably heard about the ASPRI study led by Mark Nelson, which is a very large international clinical trial addressing the use of aspirin for the prevention of cardiovascular events. Jim Sharman, who's in the audience, has been leading blood pressure research in the community for a long time. And my group have been interested in applying imaging strategies to the population. And these studies will go on after my departure to Melbourne. I'll continue to have a group here. And so the studies that we have started, TAS-ELF, the detection of early left ventricular dysfunction in the community, TAS-HELP, a strategy to try and reduce readmission in people with heart failure, all of these will be continuing. But predicated on all of what I've shown you is really this slide, and that is that we need to focus our attention. And in the course of the last 3 years, we really have done that. 3 years ago, we had 17 areas of interest in the Institute, and now we have 5. And those 5 are very important to us, and we spent a lot of time selecting them. They're important because they correspond to the major sources of death and disability in this state. So if you look at the causes of death in Tasmania, cancer and cardiovascular disease are at the top of the list. Injuries, lung problems, and mental disease follow them. And basically, all of those topics fall into our themes. These themes are part of our our current and future connection with the community and extremely important to us. I should say that we are very aware of the support that the Tasmanian community gives us. And we think the best way of returning on that investment is to show how much we produce scientifically. And academics have really three ways of measuring this. We count the number of research higher degree students that we train, we count the number of papers and the quality of the papers that we publish, and we count the amount of grant dollars that we're able to obtain from competitive sources. And I won't go through these numbers in details, but suffice it to say that Menzies has never had as many research higher degree students as it has now. There are more research higher degree student per senior academic than there ever have been previously. We've never published the same level of papers that we have now, an average of 7 papers per investigator, and taking into account the fact that not all of our investigators are full-time, probably the impact even greater. This is an institute that is very grateful for the support that we have from the community, but I want to reassure you that we are doing useful things with it. So part of this effort has been in using our profile internationally to spread training internationally, and particularly in population health. And we have a number of collaborative institutions across Asia, particularly in China, and a number of PhD scholars from China. So I have a few minutes. I don't want to take too many of them. I would sum up by saying this, that this institute is a very important resource for the state. This is a state which has substantial population health challenges, and I don't think those challenges can be addressed without having its own institute in this area. We have been successful. We need to do a lot more work to address the population health challenges of the state. So it's with mixed emotion that I move on from here. I've enjoyed the work here. I think it's incredibly important. I'm looking forward to going back to Melbourne. The Baker IDI is really one of the top cardiovascular institutes in the world, and it is obviously the area that I'm most engaged with. But part of the difficulty in leaving is really feeling comfortable that you're passing on the task to somebody else who will do it well. And I have the utmost confidence that Alison Venn is going to do the job really well. Now, my last slide really is to emphasize that Alison is renowned as a horsewoman. Now, I don't want to convey to the audience that the researchers in the Institute are obstinate beasts, but look, Alison, I'm sure that your skills, all of them, will be put to great use, and I look forward to hearing of your successes. Good luck.
Well, I have to say I've been at Menzies for 16 years. It's been a great pleasure to be here. 16 years, great privilege to be here. 16 years sounds like a terribly long time, and I would normally think that is far too long to be in one organisation. But it really doesn't seem to be the same organisation. We were about the size of about 70 staff and students in an old converted furniture store on this site, and look at us now, and we're probably around the 250 staff and students. So the university isn't the same place. This institute really isn't the same place. And it's just been very exciting to be part of the journey that's been on. So when I talk about it being a great privilege, I just want to say why that is, and there's 2 reasons really. One is really the core values of Menzies that have guided its research from the beginning are values that I hold dear, and they're one of the reasons I moved to Tasmania to be part of this institute. And they have remained a really important thread through the Institute's work, and I think Tom has highlighted some of those things. So we really do aim to do research that builds on the advantages of working with the Tasmanian population and health system, and doing research that has strong connections with the local community, and research that also has national and international reach as well. And so as director, I'll certainly be committed to continuing that core mission. The other reason that it's been a privilege is it's been really great to work with all 3 previous Menzies directors. And as deputy director, I've been able to have input into our growth and our development and our strategy and its implementation. Each director has brought their own particular style and passions and strengths to the Institute. From those beginnings in epidemiology and public health with Terry Dwyer, the building of the lab-based work with Simon Foote, and most recently, the much stronger focus on clinical research with Tom. I've learnt a great deal from each of those directors, and I really do plan to build on the foundations that they've laid down. So you can see that in terms of the future, some things will be the same, and we'll have that continued focus on excellence and on our areas of strength. So you might ask, well, what will be different? Inevitably, there'll be a few differences in style, but some of the things that will be different in the future, I think, will be in response to the challenges in the external environment. That's the researcher environment and the university sector more broadly. And we need to be very adaptable in that environment and maintain our competitiveness, in fact, increase our competitiveness. So there are 4 areas I'd like to flag just very briefly. One is increasing even more our focus on research partnerships and the application of research in practical ways to improve health. So Tom's given some really great examples of how our research has made a difference over the years. But inevitably, often research is incremental and it can be quite hard to see where it's made a difference. Sometimes those differences only are seen decades later. And the more we work in partnerships, the more we can be confident that we're asking the right questions in our research and that the end users of our research understand what we're doing and can put things into practice more easily. Reviews of medical research in Australia and elsewhere have been highlighting the opportunities for partnerships with government, with health services and industry to improve the chances of research translation. The other reason that's important is that where we can show our research has had these important and tangible benefits, we can make a stronger case for funding support in an increasingly competitive environment. Another area of real interest for me, and I know for my colleagues, is building cross-theme and cross-disciplinary collaboration. So across the themes within the Institute and with other disciplines in the university and elsewhere. Sometimes this is hard, but it's the case of putting your heads together and addressing challenging problems that individually it might be hard to do, but that together bringing different disciplines and different research experience, sometimes that can be the source of novelty and innovation and genuinely new progress. The external funding environment is extraordinarily competitive at the moment. The National Health and Medical Research Council, which we depend on very heavily, their major funding scheme, the project funding scheme, is down to a 13% success rate at the moment. Now, if that 13% were the only good research that was put up for funding, that'd just be a matter of doing good research or not. But in fact, most of the research applications, funding applications that go to the NHMRC are good, and in fact, probably more than half are excellent. So it's really about being in that 13% that's, super outstanding. And that's really tough and can be quite demoralising for researchers at the moment. So we really need to be focusing on diversifying our funding base as much as we can so that we can capture research support in all the different sources that are available. The non-government organisations and the charities are really important for us at the moment, and of course so is philanthropy and community support. That has grown over the years and we're terribly grateful for that, and we hope we can rely on that continued support. And the final kind of strategic thing for me is really developing our workforce. We do need our students and our early career and mid-career researchers to be very flexible and adaptable and able to move with the times and respond to the changing funding environment and to the changing needs of the end users of our research. So they are what you might call some of the strategic issues, and you might be wondering about the research itself. Each theme in the Institute, the themes that Tom has described, they all have a research agenda, and many of their research ideas are already funded for the next 2, 3 or more years ahead. So that's great, and they're all going to be busy developing new ideas too. When I asked each of them just this week, if in 5 years' time you could look back, what are the things you'd be excited to say had been achieved? So these are just examples or tasters of what our theme leaders are particularly looking forward to getting their teeth into. So in cancer genetics and immunology, led by Joe Dickinson, Really the focus, really Joe's hoping that we will be seeing new discoveries on how our genes influence health that will inform how we identify people at risk of disease, how we prevent disease onset in those at risk, and how we improve treatment outcomes for those who've developed disease. And we'll be having a special focus on genetic eye disease and cancers. In terms of cardiometabolic health and disease, and I know Jim Sharman thinks we have a very bright future ahead, and we do. This is an example of where the work may go in that theme. That maybe by better capturing and combining pathology test results with other cardiovascular risk factors, we could provide GPs with automatic feedback with ready calculated cardiovascular risk scores for patients and treatment alerts. And this may be a great opportunity with local health industry leaders to help determine whether this model works, whether it's cost effective, and whether we can see evidence that it's proved outcomes in the population as a whole. In the musculoskeletal health and diseases theme, Graham Jones's theme, the focus will continue with osteoarthritis. What Graham can see is that we'll have better outcomes for people with osteoarthritis through a more personalised treatment. There's growing understanding that not all OA is the same, and that by better characterising the exact type of osteoarthritis that individuals have, we will be able to target more appropriate treatments. In the neurodegenerative disease and brain injury theme, led by Tracy Dickinson, they're going to be really focusing on unravelling the mechanisms that are underlying dementia, Parkinson's disease, motor neuron disease, and multiple sclerosis. And they have some really exciting opportunities that they're already starting to work on, testing novel drugs and therapies to prevent neurodegeneration. In my own theme, which is public health and primary care, we're very used to the idea that treatments save lives, but I really want to be promoting the message that data save lives as well. We have new data linkage capacity in Tasmania, as all the states and territories have improved data linkage capacity with significant investment from Commonwealth Government. And this allows us to put data sets together in a de-identified way that protects individuals' privacy, but allows us to track how individuals use or don't use health services and other government services. And we can better understand the pathways they take and their outcomes and how we can intervene to improve them. Ultimately, data linkage is a really powerful tool to help us better plan, evaluate, and improve health services, and to support research to address some of our key social issues. We're very aware of how in Tasmania it's important for us to improve education retention, year 11 and 12. Education and health are very closely linked, and we have opportunities to better understand the impact we're having in those two areas in this state. Okay, finally, I'd just like to end on something about leadership style. It's amazing how often you get asked this, what's your leadership style? It's even a question I was asked at interview. So I've taken lessons from all the previous directors, not necessarily in a fashion sense. And I'll say more about Tom's style a bit later. But it's fair to say that sometimes it's a jungle out there, and leadership style has to be commensurate with that. When provoked, previous directors have occasionally adopted this approach. It may be a bit of a girl thing, but I find that chest beating's a bit painful. At the moment, I'm aiming for something a bit more contemplative, but then I'm still in the honeymoon period, so that may change. Perhaps a better model of the style I kind of have in mind is something a bit more like this. I think of my job as a bit like conducting an orchestra. The Institute relies very much on its talented researchers who can do a great job on their own, in their own right, but hopefully by coming together in the right way, we'll have a better end result. And I also need to lead my own research, which is a bit like being a musician and a conductor at the same time. This is one of my favourite instruments, and I'm hoping that I'll have some mellow and some jazzy research to match. And for my colleagues who know where my passions lie and who know that I like to bang on about all my favourite projects, there'll be a bit of this as well. And I think that's it for me for now. Thank you. do want to take this opportunity while we have a public forum to say thanks to Tom for his contributions, really on behalf of the staff. I'm sure you've all developed your own impressions of what a great contribution Tom has made, but these are some consistent themes that came from staff when I talked to them. They've said things like, Tom has put us on a high achievement platform and lifted our game, and there's no doubt that he has. He's been a fantastic public face and ambassador and has raised our profile locally, nationally and internationally. He's enabled clinical research, he's inspired clinicians, and he's opened new doors for us. He's been very respected by our admin team, and I know he's occasionally challenged, but also gained the respect of many in the wider university. He's led by example, not only through his extraordinary research achievements and his productivity, but also in his personal modelling of our top 10 tips for a long and healthy life. I've worked closely with Tom over the last 3 years, 3 months and 4 days, and I don't think anyone could have worked harder to achieve excellence in research, to improve Tasmanians' health, and to develop the performance of this institute. He has an extraordinary intellect, an extraordinary capacity for long hours, and constant decision-making. He has a fabulous sense of humour, often black, which has helped sustain himself, I'm sure, and it's certainly helped to sustain me and many others, particularly in negotiating the worst of the university bureaucracy. I will miss all that enormously. You'll appreciate that Tom's research focus is on heart failure. This is not the most glamorous area of cardiology. And I think it's a measure of the man that he devotes so much to a debilitating and often lethal condition that affects the elderly and vulnerable in such large numbers. It's no surprise, I think, then, that Tom has been drawn to the opportunity of leading the Baker IDI Heart and Diabetes Institute in Melbourne, which, as he said, is amongst the world's leaders in cardiometabolic disease. And we know he will have a profound and lasting impact there, as he's had here. So, Tom, we wish you every success, and we look forward to continuing collaborations. And as befits such an occasion, we do have a cake. But it's a very special salad cake.